This week on the BackTable podcast.
I think a big obligation for us as urologists is to have the tools or the numbers to have a legitimate shared decision-making conversation. I feel like that's where biomarkers help you because they give you that real good number exactly of what's the likelihood or the positive predictive value the best you can to tell the patient, this is the numbers, this is what this test says, this is what that test says. I have one study that says when you put them together, this is the risk. And like true shared decision-making, let the patient decide. At least we can give them those hard numbers so they can make an educated decision.
IsoPSA is a blood test that helps urology providers make more confident prostate biopsy decisions. Unlike standard PSA tests, IsoPSA evaluates the structure of PSA proteins to determine if the PSA protein may have been produced by cancer and to more accurately identify risk for clinically significant prostate cancer. Backed by publications in collaboration with leading institutions, IsoPSA is proven to enhance MRI results and predict risk for clinically significant cancer over time, providing clinicians with more information to make biopsy decisions and tailor patient monitoring plans. Accurate, simple, and proven, IsoPSA is covered by Medicare and a growing number of commercial plans. Learn more at isopsa.com.
My name is Ruchika Talwar. I'm a urologic oncologist in Nashville, Tennessee, and today I'm joined by Dr. Jason Hafron, who's a urologic oncologist at the Michigan Institute of Urology. Jason, why don't you take a minute to introduce yourself to the audience?
Yeah, thanks so much for being on it. I feel like I really made it. I'm on BackTable, but really a pleasure and honor to be here. I'm a urologic oncologist with the Michigan Institute of Urology. We're essentially an independent practice group in Southeast Michigan. I'm also the chief medical officer and the director of clinical boards for Solaris Health. We do a lot of work across the country in developing clinical pathways, clinical metrics, but really excited to be here and talk about a really hot area in urology.
Yeah, let's dive right in. Today, we're going to be chatting about the science driving the hopefully smarter blood tests that we can use to screen for prostate cancer. And I think this is a big challenge for us because as we know, over the past several decades, PSA screening really did change the game. We were able to screen men more effectively. We were able to save countless lives and catch prostate cancers earlier before they spread aggressively or metastasized. But there's this unique conundrum in that we sometimes catch clinically insignificant prostate cancer, and at the same time, PSA still roughly misses about 1 in 4 aggressive tumors. What are your thoughts on this challenge we face?
Yeah, I think it highlights the limitations of PSA. You know, PSA is prostate specific. It's not cancer specific. And an elevated PSA, I mean, we learned this, the first day of residency, can come from benign conditions like BPH or prostatitis. The other thing that we know pretty well is that some aggressive prostate cancers do not produce significant amounts of PSA, or the PSA produced does not reach the bloodstream in detectable quantities. Thus, the patient may have a tumor and may not have an elevated PSA above the biopsy threshold, leading to false negatives. The other issue is that the thresholds we have, whether your institution uses 3 or 4, are essentially compromises between sensitivity and specificity. Lowering the threshold increases the detection or sensitivity, but it will also increase the false positives and overdiagnosis of indolent disease, while higher thresholds will miss more aggressive cancers, but, kind of lower that specificity. And then the other thing that, we all know very well is that there's limitations to biopsying. So our endpoint is not perfect. So we know that biopsying, even in fusion biopsy or standard transrectal biopsies, will miss a lot of aggressive tumors, especially if it's a small one or if it's like a high anterior tumor. So there's a lot of limitations to PSA. PSA is a good test, and what I say a lot in the clinic, it's a good test, but it's far from perfect.
Yeah, it's tough because, I think that's the challenge for patients is they get sent to us for an elevated PSA. They come in thinking it could be cancer, and it's just a signal that there's something going on with the prostate, whether it's enlarged, whether it's cancer, so hard for us to know. And, an area that we saw that showed some promise and utility was refinement like percent free PSA or PSA density, which I do think are useful. And I'm curious, do you find these useful? How does that discussion go in the clinic?
Yeah, I mean, free PSA and PSA density added incremental gains, but they still miss a lot of aggressive cancers, and they kind of really didn't live up to the hype, and they lead to overdiagnosis and overtreatment. Pre-PSA, and PSA density are good. They reduce unnecessary biopsies, improve the diagnostic performance, but it's really still suboptimal. If you look at free PSA, which, I think there's a lot of residents that listen to the BackTable. It measures, I'll just explain what it is. It just measures the proportion of unbound free PSA to total PSA in the blood. A lower free PSA is better. So it's opposite or inverse to PSA. It's good, it's better. I'm not going to say it's terrible, but it still has a lot of limitations. And I think there's been a lot of studies over the last decade or even longer that's critically evaluated free PSA, and we see some inconsistent risk stratification, missed cancers, unnecessary biopsies. And there was this great meta-analysis that, in early 2000 that looked at almost 20,000 patients and used this free PSA cutoff of about 20%, which is kind of a little higher than what we use in our institution. But when you look at how it performed, it was 92% sensitive, which obviously is good, but the specificity still was kind of weak at 23%. The area under the curve, which is a critical number to measure all these, markers, was only 0.7. So it's good, it's better, but again, it misses and produces a lot of false positives. And in that gray zone or that tricky area of 4 to 10 PSA testing, free PSA is okay. It only really works when you get those super high or super low numbers.
Yeah, that's right. We've seen, especially in the past decade or so, a lot of movement to try to get smarter PSA testing, advances in certain fields like genomics or proteomics. So tell me a little bit about where the trend has brought us today.
Yeah, it's a great question. It's exciting, and this is what gets me excited for me, and for our patients. It's really what we've seen in the last 10, 20 years is that we've moved away from concentration-based biology, like what's your level of PSA, what's your level of free PSA, and moved into measures in molecular biology. So that there's been significant advances in molecular biology, so we can have these kind of multi-marker strategies that integrate proteomic, genomic, and transcriptomic data to improve specificity and reduce overdiagnosis and truly guide personalized management. So it's, again, not how, trying to look at the biology of these cancers and using these advanced molecular techniques to really give us better guides or better insight to whether the patient has significant cancer or is low risk or no cancer.
And we'll get into some of the specific tests in a minute, but I want to just take this idea of more specific PSA testing and think about it in the context of what we've seen and learned recently about the utility of MRI. We now have a lot of MRIs integrated into screening strategies. We know that they can potentially help overdiagnosis of insignificant disease and maybe help us be more accurate with our biopsies to find that significant disease, make our diagnostics better. When you're thinking about biomarkers for screening, is that a substitute for MRI? Do you use it with MRI? Where does it kind of fall into the spectrum?
I think we have to be clear first. So it's a great question. We got to just keep clarity here. And I think it would helpful is the guidelines. I think the AUA did a good job with the guidelines. And basically the consensus of the guidelines is that we need to do a targeted approach. We need to avoid just positive PSA, abnormal PSA, go take that patient for a biopsy of some kind. And that what the guidelines recommended is that the patient should either get an MRI or a biomarker, okay? Whatever works for you, just try to get away from abnormal PSA biopsy. The other thing what's important is sometimes lost too is the guidelines strongly recommend a repeat PSA. Never go off after one PSA, and there's been multiple studies that show, I think it's like a 25 to 40% repeat PSA is normal. So you always got to repeat the PSA. So after repeat PSA, per the guidelines, you can either get, and this NCCN are pretty well aligned, you can get an MRI or a biomarker. The issue is that, and this is why I have a strong interest in biomarkers and been involved in biomarkers, is that, we see these great publications at centers of excellence that have radiologists that are prostate MRI gurus, experts, really, really talented people, and that's all they read. But in the community, you see a lot of variability in the quality of the MRI. MRI is not like a chest x-ray where anyone can just read it and make it. It's a very complicated study for radiologists to read. There's a lot of challenges, and I think a lot of urologists don't know the performance of their local MRI. I don't think you can appropriately extrapolate what was done at a large center in a center of excellence and assume that your MRI is of the same quality. And we know that, I'm involved with music here in Michigan, and we haven't published, but we see a lot of disparity between different sites across the state. So I think when you're in the community, when you don't have these great centers of excellence or these MRI experts, a biomarker is very helpful because it kind of levels the playing field, because there's no variability in the quality of the biomarker based on geographic or local expertise. So that being said, my bias, I'm going to be a little controversial here, is I tend to order a biomarker and MRI when I see a patient after I've repeated their PSA or they've had a couple elevated PSAs. I'll do both. If we get a normal biomarker, like we pretty much stop there. If the biomarker's elevated, then I would, consider or get them ready for an MRI. I do it together because it's just more efficient. I mean, just to deal with the volume of these patients and to get these patients tested and kind of for throughput. But I think it's been very helpful for me. It's worked out well. There's been a couple good studies that have looked at the combination of MRI and biomarker, and I kind of based my thought process on these studies. I think one good study that we saw, or was just preliminary results, were just published. It's the ProScreen study. I don't know if you've seen that one or heard about that, but it's a pretty cool trial. It was 60,000 men in Finland, and their endpoint is they wanted to look at the primary endpoint for, it's essentially a screening trial, is mortality. And what they did last year in JAMA was just publish their initial exploratory results, not their primary endpoint, which is mortality, which obviously will take 10, 15 years, who knows. But it was kind of cool because the patients were randomized to screening versus no screening. And those that were randomized to screening group or the active group underwent a serum PSA. Their PSA was greater than 3 or higher. They underwent a 4K blood panel. If the 4K was positive, 7.5, which is the standard 4K result we see across the country, they underwent a prostate MRI. Those who had an abnormality on prostate MRI underwent a targeted biopsy, no template biopsy. That's just what's done in Europe, not done here. And then the patients who had a positive 4K, negative MRI discordant result, those patients, if they had a PSA density greater than or equal to 0.15, they underwent this 12-core biopsy. So again, a little complicated, a lot of words there, but the bottom line was, which is kind of exciting, was that they found this, basically, if you compare it to the European trial with just PSA screening, it was about the same number of high-risk patients, okay? So you still find all these high-risk, same amount, but their low-risk patients went almost below measurable to 0.4%. So PSA, 4K, MRI, you really eliminate that finding that low-risk cancer or non-lethal prostate cancer, which you never want to find in anybody. So that was a cool study, and that kind of just opened my eyes to say, maybe we should probably use these together.
Yeah. I think your strategy makes sense. I'll just ask you quickly, if I'm hearing you right, you'll do the tests together. Now, if the biomarker is negative, then you said you stop. What if you get the MRI back the MRI is negative, but the biomarker is positive. So then you're just doing a standard 12-core biopsy.
Yeah, so that's a challenge, and that's frustrating. That's, discordant results. Discordant results are your urological nightmare because, you have one thing saying yes, the other one saying no. And I think there was a couple thoughts on that. There was a great trial from Cleveland Clinic, published it in the Gold Journal, and they basically retrospectively looked at all their patients who had MRI, IsoPSA. IsoPSA is another biomarker, and underwent biopsy. And what they did was that they looked at does the IsoPSA add to MRI, and they have this great table in the trial. And if they have a normal IsoPSA, a normal PI-RADS 1 or 2, the risk of prostate cancer is like 2%. If they had a PI-RADS 3, which comes up a lot, like you have this 3, do I want to biopsy it? Do I want to watch it? What they found is if they have a negative IsoPSA, the risk of prostate cancer is less than 5%. So negative ISO, normal MRI, risk of prostate cancer is less than 5%. But if that guy has a PI-RADS or the patient has a PI-RADS 3 lesion, abnormal ISO, that risk goes from less than 5 to 16%. And then if they have a 4 or 5, the risk of prostate cancer in a normal ISO is like less than 20%, and then it approaches about 50% with abnormal ISO, abnormal MRI. So I think it's a lot. So I keep this table in my clinic just to keep it straight. But I think another point is, you asked about discordant results. I think a big obligation for us as urologists is to have the tools or the numbers to have a legitimate shared decision-making, conversation. I feel like that's where biomarkers help you because they give you that real good number exactly of what's the likelihood or the positive predictive value the best you can to tell the patient, this is the numbers, this is what this test says, this is what that test says. I have one study that says when you put them together, this is the risk. And like true shared decision making, let the patient decide. At least we can give them those hard numbers so they can make an educated, decision.
Yeah, no, I think that makes a lot of sense. And I think I like what you're describing using, for example, in the study that you quoted, it was IsoPSA with an MRI, because that helps overcome some of the inter-reader variability. For example, a PI-RADS 3 may be a PI-RADS 3 to one radiologist, which may be a 4 or 5 to another. But this way, if you have a concerning test, you're still targeting an area that was identified as a lesion, and it helps assuage some of the uneasiness from maybe foregoing a biopsy in a PI-RADS 3. So that makes a lot of sense to me. Let's stay on the topic of IsoPSA specifically because we're talking about this one study. Tell me about the test. And you mentioned 4K, so we'll get into that next. But let's talk about IsoPSA. What is it? What is the mechanism there?
Yeah, so I've been involved with IsoPSA. We were part of their initial validation trials going back to 2018 and even before that. So I've been using this test for a long time and use it now it's commercially available. So I have a good amount of experience. And the beauty of IsoPSA, it's a blood test, and it's designed to improve prostate cancer risk assessment beyond conventional PSA. So you order the ISO, you get that repeat PSA, but then you get this index score, the IsoPSA number. Below 6 is normal, above 6 is abnormal. But what's cool about it is, unlike traditional PSA, which measures the concentration of PSA or the PSA protein, IsoPSA focuses on detecting cancer-specific structural changes to PSA. So they use this technology called solvent interaction analysis, but they basically measure how these IsoPSA proteins or these isoforms of PSA separate. And what they found is it's more accurate. I mean, it performs better than a standard PSA test or even a free PSA.
And how does that differ from, for example, 4K, which you brought up?
4K is, I think all of these tests are good. I'll never disparage or talk badly. 4K looks at kallikrein technology, or 4 different types of kallikreins, which are PSA, and has a proprietary algorithm to predict outcomes. But what I like about ISO is that it has 80% accuracy or better in predicting high grade. So the cancers that we care about. And if we can get through all these numbers and do it. But like when you really look at it, it's 3 times more specific than a standard PSA and 2 times more specific than a free PSA. And those are kind of just like the numbers I keep in my head why I use this test. And it basically tells you, which are clinically significant grade group 2 or higher prostate, the likelihood of grade group 2 or higher prostate cancers. And in multiple studies, IsoPSA has been around like for almost 7 years now. We see a significant reduction in biopsies. Large centers have looked at this and, looking at the clinical utility, you can see up to a 55% reduction in biopsies. So you're biopsying patients that need it, and it has a very good positive predictive value. So I found it very helpful. I think patients appreciate this, going that extra step, whether it's 4K, ISO, or any of the other, 6. These are, patients know that, we started this conversation as PSA is good, but they've definitely heard or seen on the news that it's not perfect.
Great point about the news. I've had patients come into my own clinic and talk about all these people who've been recently talking about their prostate cancer diagnosis, and it really shapes the way our conversations go. Just for the sake of completeness, what are some other tests that we can consider? So we talked about ISO, we talked about 4K. Any others on your list?
Yeah, I go by, if you look in one of the footnotes of the NCCN guidelines for it, there's 6 that they list. There's 4K, ISO, Phi, which is one of the original ones, SelectMDx, MIPS 2.0, and ExoDx. So I think like the guidelines, I think they're very appropriate. I think it's use a biomarker. What we tell my partners is use a biomarker that makes sense to you. They all perform pretty well, what you can explain to a patient in a reasonable way. But I think, again, the key is use it, whatever works for you. Like Exo and MIPS are urine-based. Sometimes that might work better in your clinic. For me, urine-based is always kind of a pain because the patient just comes in, urinates in a cup, and you go see the patient, and you can't get the urine. So I like a blood-based test. I like the simplicity of ISO. But again, that's my personal preference. I think the key or the message here should be use a biomarker to help better stratify the patients that need a biopsy and the patients that are at risk for clinically significant prostate cancer.
Yeah. And I think we talked about the utility of these sorts of tests in the screening patient, but I want to push us a little bit and I want to get your thoughts. I think we all struggle with active surveillance as well. A patient's been diagnosed, they have low risk cancer. How often am I biopsying? I mean, I can't tell you how many patients in my clinic I see with active surveillance who are like, I never want to go through that again. I can offer them a biopsy under anesthesia. Still, they say, no way, I don't want to deal with that again. It's a real problem, right? Because sometimes those patients are like, just treat me. I don't ever want to have a biopsy. So how do you use these sorts of tests? Although it may not be in the guidelines yet, like where do you think there may be some utility to build these into a surveillance strategy?
Great question. I feel the same way. Patient doesn't want the biopsy. I don't want to do it on this patient. You kind of start to feel bad for these guys. But I think we got to be very clear here is that there has been no prospective active surveillance biomarker trial, and there may never be. This would take years. Look at the ProScreen trial. That's like 10 to 15 years. Like there's going to be something else. Hopefully, great things. What's cool, again, I hate to keep going back to IsoPSA, but ISO did a longitudinal outcome study. So they looked at IsoPSA, again from Cleveland Clinic, but 1,500 patients. And they looked at the patients that had a normal ISO and then patients had an abnormal IsoPSA, and then they followed them. And they just wanted to see, which I think is important because we know the limitations of biopsy, are we missing cancers? And what they found was that those who had a low IsoPSA or normal IsoPSA, their risk of clinically significant prostate cancer over a 30-month, so intermediate numbers, remain low. So we, theoretically, this can be, hasn't been studied exactly. IsoPSA can be a surrogate for active surveillance in that if they're low, we know based on the study about 30 months, they're going to stay low. I don't think any of these tests are perfect, but you might not follow them as closely. You might not order that MRI as yearly. You might obviously avoid a biopsy because you have less risk. And I think it helps with your conversation with the patient, But if a patient has abnormal IsoPSA, you just found grade group 1, you're going to follow them. You might adjust your monitoring strategy because they're still at a higher. So I think these help with intensity of your protocol for follow-up, how often you're going to biopsy, how often you're going to MRI. There also was a study, it was kind of a little disturbing, just came out last month. I don't know if you saw it, that looked at short and long-term results using 4K. This was a large European trial, again, over 1,500 men, was published in the Journal of Cancer Epidemiology Biomarkers, not a common journal, but what they found was that 4K didn't significantly improve the prediction of clinically significant prostate cancer compared to total PSA. So it only helped. There was a signal in young men, less than 60, with an elevated PSA and a 4K result. But generally, overall, the study didn't show that 4K in long-term or intermediate term to be predictive over a standard PSA. I think it's appropriate that we need a biomarker. We need to stop biopsying these patients. Mm-hmm. Hopefully, in our time, we'll develop a biomarker so we can avoid these situations and just minimize our biopsies and MRI. MRI also is, I don't know but what it's like in Nashville, but it takes a month to get the patients in. The centers are backed up. It's a pain in the butt. So if we can minimize that, that would be a big innovation.
I totally agree. Imaging is getting harder and harder to push through these days in a timely manner. And, another frontier that I think is relevant for both imaging, we talked about inter-reader variability as well as improving some of these biomarkers, is AI. I mean, I talk about it all the time. I think it's the next frontier. We all know that. But, I just want to pick your brain. You have had a lot of experience with these biomarkers. How do you see the future going? I mean, beyond just AI, how is that going to build in? Or, we're seeing some products out there that are integrating imaging with tissue, with PSA and all of this. And I'm excited. So I'm just wondering, I know that's more in the active surveillance and risk stratification category, but what about in screening? What's out there?
To me, I can't wait to see what the potential of AI, and I could totally agree. It's going to be this like multimodal. It's kind of like with the risk calculators we use today, which are kind of very basic, but taking those risk calculators, developing true AI where the computer can make decisions or even just do machine learning, can make better predictions. But age, genetics, previous biopsy history, take all that information and then take a biologic marker and put it together so that, again, we can go back to that patient with higher sensitivity and specificity with a great area under the curve. I mean, it would be great if we could get with a multimodal AI platform, get an area under the curve to like 0.9 in the nines. And I think that's what it probably will take, because when you put all these things together, it definitely makes this testing accurate. And then you can have that conversation to say, this is probably what you need, or this is the likelihood you have cancer, or even get to a point where we could run a model or whatever that looks like and not have to follow their PSA every, 6 to 12 months and not have to worry about them. Because these tests are good today, but they're not perfect. We don't have a test now where we can say, your ISO, your 4K is normal, just call me if you have a problem. We know that's not good medicine or good urology. So, I mean, I'm excited for the future. AI is very exciting. We're seeing a little bit in bladder cancer. We're seeing it in genomics and in prostate cancer. I think elevated PSA, like you said, is ripe to process all these information. I think the key is to just find data sets where you can evaluate these patients and put in all these numbers and create these tools.
Yeah, absolutely. I'm excited for the future too. As we wrap up here, any final thoughts for the audience?
I think biomarkers are additive and probably should be combined with MRI, even though the guidelines say one or the other. But I think you really have to critically look at what the performance of your local MRI is, if that data is available. Try not to extrapolate what's done in these great centers, because you may or may not realize is most of these radiologists are MRI specific. They read about it, they breathe it, they dream about it. Most of the, in our centers are general, body MRI, and they all over the place. I think these are very helpful, especially to better guide decision-making, especially shared decision-making with your patient, because it gives you that actual number much better than, these vague descriptions of risk that we commonly fall trap to in day-to-day clinical care.
Yeah, well, this is such an important topic. Again, an area that we've both stressed is ripe for innovation in the future. And we're grateful that you joined us today to share your thoughts.
Thank you. It's my pleasure. Really an honor to be here.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.